Working with first responders can be very challenging for us as therapists. We need to understand the culture of the population that we are working with. We also need to understand the experiences that our clients have been through and how we can work more effectively with them. In this video, I want to help you become the best you can possibly be in working with first responders. Please join me. I'm Dr. Michael Paterson, clinical psychologist and EMDR Europe accredited senior trainer. Since the 1990s, I have been working with first responders, helping them overcome the psychological trauma that they experience as a result of the work that they do. In some ways, I've had a bit of an advantage because I served as a police officer in Northern Ireland, and that's how I lost both my arms. It was an attack on my police vehicle in 1981. Of course, that's another story. But back to the population that we're considering working with. First responders are extraordinary people. They're doing an extraordinary job, and they're having extraordinary experiences. In fact, the experiences that they have are experiences that many of us will never have in our lives. In fact, given the opportunity, they are experiences that we would never want to have in our lives either. Because first responders see the worst of human suffering. They see people die in front of them. They might feel helpless as they see somebody's life slip away. But how can we work effectively with these people? When they are faced with such experiences, they cope up until the point. They tend to be resilient individuals. They can soak it up. They're trained to deal with such things. But the resilience only works up to a point. It's like this glass. You can see in this picture, the water level is well down the glass. But if we were to fill the glass up to the top and added just a little more, the water would spill over. If we added a lot more will spill over too. We see this capacity to cope being challenged in the emergency service personnel. They can soak it up to a point, but then it becomes too much. And it could be something minor that tips it over the top, like the straw that broke the camel's back. Our clients are exposed to these different events, horrific experiences, but also they could be exposed to life threat situations. For example, the firefighter in fighting a fire. Then there's a flashover, or you might know it as a backdraft. The flames are now behind them. They're cut off. A life threat situation. Or the police officer who is called to a domestic dispute. Going in to deal with this, both parties turn on the police officer and now threatening the police officer with a knife. That can be quite frightening. Or the paramedic who now gets attacked by an addict who wants to get access to the morphine that's in the ambulance. That personal threat can be very significant. Think of it this way. If I were to say to you, if you were sitting in a room with a number of other people, somebody is going to come into this room and shoot somebody. Well, it's a generic threat, isn't it? But if I were to say, somebody is going to come into this room and they're going to shoot you, how does that feel? It feels a lot different. So that personal threat, that life threat situation can have a marked impact. We need to consider what our clients are presenting with. Our client may well have intrusive recollections of a particular experience. There could be nightmares. There might even be dissociative flashbacks. We need to consider, what does this client need immediately to help them cope? Alternatively, the client may well present with anger. It could relate to an experience that they've had within the job. If you think about it, they have been putting themselves on the line, perhaps going above and beyond of what the job requires. They need support and they're entitled to support from their management. But if it's missing, that can have a marked effect. Indeed, what may also happen is that our clients are presenting with recurring distressing recollections about past experiences, not necessarily related to their job, but linking back to earlier life events, even back into childhood. Just like us, first responders are born into this world and they have experiences. And as we know, if people have adverse childhood experiences, 4 or more, then they are at greater risk of developing mental health issues and physical health issues in much later life. We need to understand the client's history, in addition to the more recent experiences that they have had working as a first responder. Where do we start with our clients? Well, we need a history. We need to understand the client's history from the start of their life up to the present, but also the history of experiences that they have had in the job working as a first responder. If the client isn't functioning in the here and now as a result of experiences that they have had in the job, such as nightmares, intrusions, and maybe the dissociative flashbacks, it makes sense to target that first. By doing that, it can help our clients start to function again. But when did this particular experience happen? If it was in the last few weeks, well, natural healing might still be taking place. If that is the case, then I want the brain to do its own natural healing, supported by me, of course. So I will be teaching my clients strategies to lower the arousal level. The calm, safe place, for example, diaphragmatic breathing, the light stream, anything like that that lowers the arousal level will be helpful to the client. If the client is having those intrusive recollections, I've taught them the methods of self-soothing, I'm reviewing again within a short period, at least 2 to 3 days later, maybe a week later. If it turns out then that the client isn't functioning any better and there is no natural healing taking place, I will consider using the recent events protocol to help the client deal with it. You may recall when Shapiro developed the recent events protocol, then it's working on a recent past event, something that has occurred within the past 3 months. Using that recent events protocol, treating a number of sub-traumas within the overall experience, we can use the standard protocol. Or we might use EMD. Which is the right one to use? It will depend. If the client is on a continuum of complexity from the well-adjusted to here, the most complex client presentation, then that will give me a good idea of where to start. If my client is from well-adjusted to round about here on this continuum, I would use the standard protocol on the recent events. However, if the client is from about here to further down this continuum of complexity, I would probably use EMD, eye movement desensitization, to get a desensitization effect on that particular memory or part of the memory. It helps keep the client contained and prevents the client from going down the associative channels, which is what could happen using the standard protocol. If your client isn't ready or able to go down those associative channels, it makes sense, of course, to use EMD. Having done that stabilization for the client and got the client functioning again, we can now bring our attention to the other past events that are there in the client's history. Remember the 3-pronged protocol of past events, present triggers, and then the client's desired outcomes for the future. I hope this video has been helpful to you. If it has, please click like down below. If you haven't already subscribed to this channel, please do so. It's free. YouTube can then let you know if other videos in the series are published. I want to help you become the best you can possibly be in delivering EMDR therapy, and of course, becoming much more effective in your practice so that you too can help first responders. Thanks for watching.